Good day. So it is a distinct honor to present my research, and it's a great segue. We heard from an excellent speaker. Thank you for the very insightful presentation on atrial fibrillation and some of the factors that are related to that pathology. I'm shifting gears here now, looking at some of the broader aspects outside of the individual biological profile that have an impact on cardiometabolic health. Specifically, my research is titled "The Role of the Food Environment on Cardiometabolic Health," and this is from a large cross-sectional study on type 2 diabetes risk. So the traditional view has often focused clinically when we look at cardiovascular disease, cardiometabolic disease, including diabetes, hypertension, and the whole array of metabolic syndrome has been treated primarily as really the dispositive factors that have an impact on disease development and progression are more individual in nature. So their biology, their genetics, diet, exercise, things of that nature. That's the traditional clinical view. But emerging epidemiological research has now suggested that, in fact, the clinical view doesn't capture everything. We have to look at the ecological view. We have to look at the environmental factors within which individual patients reside and how that can have a decided impact on an individual's propensity for cardiometabolic disease. So here, this slide looks at deconstructing the food environment. So what I've done here in this schematic is essentially shown how the individual's biology, genetics, age, gender is only one part of the picture. And what we're looking at, and this conceptual model is based off of Gland's seminal work, where environmental factors, including the consumer environment, such as in-store marketing, food pricing, product placement, even things as simple as product placement in stores, has an impact on individual health risk. Similarly, if we go beyond that, the questions of the community, so geographic accessibility to healthy food sources, location, density of retail food outlets, has a decided impact not only on consumer behavior, but also an interplay with an individual's own biology and genetics that has an impact on the development and progression of cardiovascular disease. So this study was a very large big data study that was conducted in Canada, known as the Cartagena study. And the Cartagena study included more than 43,000 participants in the province of Quebec. And essentially, more than 43,000 patients were involved in a biobank across the province of Quebec, which is on the northeastern side of Canada. And amongst these 43,000 patients, in my particular study, 8,405 adults were then analyzed in a cross-sectional study. We looked at 6 major metropolitan regions across the province of Quebec, including the largest metropolitan region, the region of Montreal. Quebec City was also included. Three Rivers, or Trois-Rivières, was another metropolitan area considered, and remaining other composing the 6 major metropolitan regions across the province of Quebec. And what we were able to do is operationalize this question of geographic accessibility. So access, as I mentioned before, is both a construct of spatial and temporal factors. So what we did in this research is that we mapped 1 kilometer or 1,000 meter buffer zones, around individual residential addresses to calculate 2 dimensions. Dimension 1 is the proximity to food sources, and that's the distance in meters to the nearest supermarket, to the nearest convenience store, to the nearest fast food outlet. And the second dimension that was studied was the density. So here we're looking at the concentration and the ratio of fast food outlets within the immediate environment that an individual household has in its accessibility. Now, we used statistical models, we used multiple logistic regression to control for individual biological and socioeconomic factors to really decipher what's the impact of that broader environment, the geographic environment, on the risk for type 2 diabetes. So individual variables that we looked at include age, sex, BMI, body mass index, income, education, and diet. We then looked at the next tier of neighborhood variables. We looked at, calculated what was known as the material deprivation index. And then finally, superimposed environmental variables, including distance, density of food outlets, and other indices to look at risk factors for cardiometabolic disease. We put this in a multiple logistic regression model in order to study the predictive risk for these factors that you see on the left of your screen, and it's their weighted risk for the development of type 2 diabetes. So as a clinician, we expect that certain individual factors drive disease expression, and some of those are high income. So especially we noted that when income in a household was greater than $200,000, and these are Canadian dollars, that was a protective factor or served a protective role in terms of an individual's risk for type 2 diabetes. Similarly, the other side of the equation, patients or subjects that were either overweight or severely morbidly obese had significantly higher, statistically significant odds ratios for the development of cardiometabolic disease, in this case, type 2 diabetes. So we look at severely obese patients had an odds ratio of 14.6, and high income has a protective effect, so an odds ratio of 0.10 when insofar as what's concerned for the development of type 2 diabetes. However, we deciphered what I'm terming the proximity paradox, which basically it's that extant literature and thought on the subject suggests that living adjacent to fast food chains, so your typical fast food chains that we see often in North America, like McDonald's, Burger King, and as such, the myth is that living adjacent to having those in your backyard directly drives individual type 2 diabetes onset. However, the reality of what we saw based on more than 8,000 subjects in this data bank was that while proximity and density of unhealthy food outlets were positively associated with the type 2 diabetes risk, these relationships each and together fail to reach statistical significance in the multivariate regression models. So the presence of bad food alone does not dictate disease development and progression. What is more interesting are the results that we were able to derive and what I'm terming here as the neighborhood diagnostic matrix. So we're looking on the left side, we see healthy food access, deprivation index, and subsequent type 2 diabetes risk. On the top, we see high socioeconomic status neighborhoods that are classified as a food swamp, and neighborhoods that are classified as a food desert. So the difference between food deserts and food swamp, a food desert is there's simply lack of an accessibility to healthy food choices. So we're talking about supermarkets where fresh fruits and vegetables can be acquired, or open air markets or farmers markets. These are the absence of which is termed a food desert, whereas a food swamp is a highly dense area that's rich with poor food choices like fast food outlets, convenience stores, and things of the nature. So what we found was that the type 2 diabetes risk was the highest, very interestingly, in the subset of in the matrix where there was the presence of a food desert, and that was the highest driver of type 2 diabetes risk. So in this case, there's low healthy food access, there's high material deprivation, so there's lower socioeconomic status, and the type 2 diabetes risk is high. Interestingly, when we look at the food swamp, here you have high healthy food access, but you also have high unhealthy food access. The material deprivation index is considered moderate, and the type 2 diabetes risk is actually it ends up being moderate as well. Conversely, when we look at the high socioeconomic status neighborhood, as we expect, there's a high healthy food access, there's a low material deprivation index, and the type 2 diabetes risk is low. So interestingly, the absence of healthy alternatives, so the lack of healthy food access interacting with structural poverty in a given neighborhood is the highest driver for type 2 diabetes risk. So when we look at the material deprivation index, and this is an index that is based on standardized indicators of income, education, employment, we see that in the highest quintile, so the fifth quintile of the neighborhood material deprivation index, residing in those neighborhoods significantly multiplies the risk for having type 2 diabetes. Here, the odds ratio is 1.5, even when controlling for individual dietary habits and BMI. So when we control for those individual factors, we still have, in terms of ultimate disease status, we still have the highest odds ratio. Now, what's interesting, what we show here is the results of our multivariate regression model, that residing in that food desert where, and as I mentioned, it's a geographically isolated area, low access to healthy food, combined with severe socioeconomic deprivation, it creates almost a perfect storm for catalyzing the development of individual type 2 diabetes risk. So it was the only purely geographic indicator statistically significantly associated with an increased risk of type 2 diabetes in our model. Now, what that leads is how we can kind of conceptualize this concept of the sociogeographic web of diabetes, of type 2 diabetes. And again, we're using here type 2 diabetes as one of the essentially main indicators of cardiometabolic disease, but presumably this would be something future studies where we would be able to see if the same kind of findings are for hypertension, cardiovascular disease, and other chronic diseases. Now, if what we're showing here is an evolving conceptual model where the individual biological factors, if we think of a barrel of a gun, essentially, your individual BMI, age, this is essentially loaded into the actual barrel. But when you have other factors such as the individual income, education, so that creates what I term a socioeconomic shield to somehow prevent the phenotypic expression of the biological genotype. And finally, you have this modifier, which is food deserts and neighborhood deprivation, which in fact transform into an environmental multiplier, which are able to significantly statistically increase the risk for type 2 diabetes progression, development and progression. So the study is interesting not only in that it pushes the limits and expands our understanding of what are the drivers for type 2 diabetes risk and allows us to think outside the biological quote unquote box where we're sometimes very much focused clinically as clinicians, focused clinically on the individual's biology and genetics, but and we often our therapeutics often are geared towards that in those individual factors. Here, our studies suggest that when we're looking at things from this problem from a public health standpoint, we need to not be solely focused on the individual biological factors, but rather clinical intervention is only one side of the picture. So we need to continue, obviously, the aggressive management of individual risk factors as physicians, treating obesity, treating age-related metabolic decline, cardiovascular disease, hypertension, diabetes, metabolic syndrome. But there is an important role for public policy to play, in public health to play, in terms of developing environmental policy, where geographic food availability in different neighborhoods are restructured. Zoning is restructured in order to eliminate this concept of food deserts. So regardless of individual socioeconomic status, there are healthy food options for the individual patients in these areas. And finally, we need to do an entire structural revitalization, which is to address the overarching neighborhood socioeconomics and material deprivation indices, because as I had stated earlier and our results have shown, that aspect of material deprivation is a significant driver for type 2 diabetes risk. So again, these results were quite interesting in that they allowed us to think outside the box. This is a study that was conducted in Canada. So a lot of the limitations of this research is its applicability elsewhere. Sometimes in other countries, in other areas, especially developing countries, this concept of a dichotomy of or specific zones within different neighborhoods where there's specific socioeconomic criteria. Sometimes that's blurred, where there's a mix of different kinds of socioeconomic environments within a single city, and in which case the results need to be catered to the actual environment in which we're studying. But our results nonetheless show that the microcosm of the environment within which individual patients and subjects reside has a macro effect on their health. So the micro and macro factors have a decided impact on individual health factors or health disease states, especially as it pertains to cardiometabolic disease and type 2 diabetes. So in sum, our research showed that the paradigm must shift from solely looking at the patient's biological factors and their individual habits, including dietary, exercise, and other habits, but rather also look at the environment within which each individual patient, subject, person resides, because that environment has a significant impact on the individual health risk. Thank you very much for your time and attention.